population. We study early life neurodevelopmental conditions on one end and late life neurodegenerative decline on the other. But recent analyses of Medicaid and Medicare data, examining over 114,000 autistic adults, break that separation. Across this specific population, the baseline dementia diagnosis rate sits at 8%. Take a look at this chart plotting dementia prevalence by age. While we expect a steady rise in the standard population, the curve for the autistic adult cohort without intellectual disabilities climbs sharply, peaking with a 35% prevalence rate by age 64. Autistic adults face a 2.6 times higher risk for early onset dementia. When we look at familial patterns, relatives, particularly mothers of autistic individuals, also show elevated dementia risk. Not every autistic person will develop Alzheimer's, but the consistency of these patterns indicates shared genetic and environmental vulnerabilities. Recognizing this overlap forces a reevaluation of lifespan brain health. It suggests that the biological vulnerabilities present in early development continue to operate decades later. We can map out exactly how early life autism and late life Alzheimer's intersect. This three-column matrix aligns the early and late conditions with their shared biological mechanisms. The first overlap is chronic low-grade neuroinflammation. In both populations, the brain's primary immune cells, the microglia, become chronically triggered. Rather than remaining at rest, they shift into an active inflammatory state, releasing a constant wave of cytokines. During early development, this aberrant activation disrupts normal synaptic pruning, altering how neural pathways form. Decades later, that exact same pattern of microglial activation accelerates neural decay, driving the progression of late-stage degeneration. Specific genetic primers predispose both populations to these inflammatory failures. We see overlapping genetic signatures involving mTOR signaling pathways, alongside a higher frequency of the ApoE4 allele in some autistic populations. These genetic overlaps compromise cellular energy pathways and impair overall mitochondrial function. Because compromised mitochondria struggle to meet the cell's energy demands, they exacerbate the existing neuroinflammation, locking the system in a biological feedback loop. These cellular failures do not stay microscopic. They scale up, destabilizing the central nervous system. The result is a documented disruption in synaptic connectivity, accompanied by the specific dysregulation of gamma rhythm oscillations in both populations. Because both conditions share identical inflammatory primers and genetic operators, regulating the inflammatory response for early developmental needs logically supports neuroprotection against later decline. Cellular inflammation is only half the equation. We also have to look at systemic autonomic nervous system function. A critical metric here is vagal tone, which dictates how efficiently the brain regulates the body's internal state. Looking at this ECG trace, we often see a rigid, low heart rate variability pattern, indicating poor vagus nerve signaling. In autistic individuals, this lower baseline heart rate variability and reduced vagal tone manifest directly as severe sensory processing challenges and emotion dysregulation. In older adults, we see the exact same autonomic inflexibility. A rigid autonomic nervous system tracks closely with the onset and progression of cognitive decline. Biological rigidity is a shared vulnerability across the entire lifespan. Inducing autonomic flexibility becomes a necessary therapeutic target. The clinical principle here is straightforward. Providing non-invasive structural input regulates biological function. One highly precise protocol is resonant frequency breathing, combined with heart rate variability biofeedback. The patient breathes at an individualized slow rate, targeting between 4.5 and 7 breaths per minute. This biomechanical schematic illustrates the underlying mechanism: respiratory sinus arrhythmia. This is the physiological phenomenon that links the pace of respiration directly to the rhythm of the heart. By locking in a specific pace of 6 breaths per minute, the physical movement of the lungs forces a maximization of heart rate variability via that reflex. When this protocol is applied to autistic youth, clinical pilots report significant reductions in anxiety and measurable improvements in vagal modulation. The biofeedback is monitored through a simple ear clip or app, making home-based daily practice highly accessible. We see comparable results when applying this exact breathing protocol to older adults and populations with mild cognitive impairment, improving attention and memory. The systemic effects extend down to the molecular level. Documented studies link this specific paced breathing to a reduction in plasma amyloid beta levels. The physical act of slow breathing activates the vagal and noradrenergic pathways, which actively facilitates the clearance of these known Alzheimer's biomarkers from the bloodstream. A purely mechanical breathing intervention physically alters the pathological biomarkers of neurodegeneration by exploiting the body's shared autonomic network. Beyond breathing, we can introduce non-invasive mechanical inputs through structured therapeutic frequencies. Delivering a 40 Hz acoustic wave provides a physical rhythmic input that propagates through neural networks to stabilize erratic oscillations. Specific auditory inputs like alpha and theta binaural beats or brown noise provide necessary sensory gating, helping to calm arousal and manage sensory overload in autistic individuals. Conversely, 40 Hz gamma entrainment specifically targets Alzheimer's-related pathology, reducing amyloid load and supporting cognition in early human studies. We can also supply structural input electrically using non-invasive transcutaneous vagus nerve stimulation, or TVNS. The clinical parameters involve auricular stimulation delivered at 10 to 30 Hz over 20 to 60-minute sessions. This anatomical schematic shows how the electrical pulse travels up the afferent nerve pathway from the outer ear into the brainstem, triggering the cholinergic anti-inflammatory pathway. Activating this pathway prompts a downstream release of acetylcholine, which physically dampens central neuroinflammation and modulates the gut-brain axis. Targeted electroacupuncture utilizes these exact same vagus-mediated mechanics, leading to documented improvements in sensory processing, behavior, and communication in autism. Practitioners target specific acupuncture points, combining ST36 on the leg with precise scalp and ear placements over short clinical courses. These tools are entirely complementary. A patient can practice resonant breathing while undergoing a TVNS session or pair electroacupuncture with calming sound. Delivering structured frequency, whether acoustic or electrical, acts as a mechanical override, actively suppressing the shared inflammatory drivers that fuel both developmental distress and degenerative decay. The clinical science points directly to a set of practical, low-risk, and home-adaptable protocols. We can map this on a two-sided stewardship timeline. Short-term, for immediate sensory regulation during stress, patients use a breathing pacer and structured audio. Long-term, daily HRV biofeedback layered with TVNS yields compounding effects, sustaining vagal tone and suppressing neuroinflammation. To be clear, these interventions do not guarantee the total prevention or reversal of Alzheimer's disease. They operate under a clinical stewardship model. Families work with practitioners to integrate these inputs with holistic lifestyle factors like consistent sleep, movement, and nutrition to foster biological resilience. By utilizing non-invasive tools to treat the immediate sensory and autonomic needs of the neurodivergent brain today, we actively deploy a blueprint to protect